We are now going to move on. I'm really delighted to introduce Siobhan Quenby, who's Professor of Obstetrics at University of Warwick and is also one of the co-leads of the Tommy's National Centre for Miscarriage Research. And I think Siobhan is basically the expert on recurrent miscarriage and has done a huge amount of the work on this and a lot of the science related to it. But not only that, has a very big clinical workload and is hugely experienced on caring for women with this, well, it's a huge problem for them. I mean, you know, as I say with Frida Kahlo earlier, so many women either end up not successfully having a pregnancy or are convinced they never will do. So Siobhan, thank you for making the effort. Poor Siobhan, as I said earlier, I was stuck in the middle of the English countryside for about an hour and a half, basically being told, there are no trains to London today, so don't bother. I mean, for those of you who want to make a donation to the British economy, particularly if you're listening overseas, an online GoFundMe page for the Treasurer and for the English government, so do give generously, and maybe we'll have a train service that works. But anyway, Siobhan, over to you.
Thank you very much for the introduction, and thank you very much for inviting me to yet another excellent conference that you've organised. You've asked me to talk about these aspects of recurrent miscarriage. When should we investigate? What tests are worth doing, and what treatment works? So this is because Tom and I are both part of the National Centre for Miscarriage Research. There's obviously going to be a lot of overlap between our talks. So this is just conflicts of interest. I'm a clinical advisor to Calla Lilly, and I've worked on Kimnel, on the Quenby Cradle, which I'm going to tell you about, but I don't actually receive any money for it because I'm not a business person.
That's foolish.
Because I'm foolish. Exactly. So these are the topics I'm going to cover, and I'm going to start with the paper that Tom's already mentioned. It's really important to realise how common miscarriage is. There's 23 million miscarriages that occur every year. That's 44 pregnancy losses each minute. You know, all those pregnancy losses have physical consequences, as we all know. You have pain, bleeding, and infection, but it's probably the psychological damage that's much more important, as you've had it clearly explained to you already. That's the anxiety, depression, post-traumatic stress disorder. So when we think about the question, who should we investigate, I think it's important to go back to the original epidemiology and say, really ask that question, who should we investigate? So at the top one of these graphs, you can see there's a J-shaped relationship between age and risk of future miscarriage. And you can see if you put that graph on the side, it exactly mirrors the risk of aneuploidy that's been detected when people are doing IVFs, you know, when they do IVF and they now test the embryos. And so why is this important? So can we use age as a cutoff to tell us who we can investigate? But then it's quite difficult, isn't it? So you can say, well, like, we're only going to investigate young women because, in fact, clearly older women are having mainly aneuploid miscarriages. So if you take someone who's over 42, you're talking about 60 or 70% of their embryos when they do IVF are abnormal. So, you know, it's really hard for women who are trying for pregnancy in their 40s because they do have this high age-related miscarriage rate. So then the question is it worth looking for other issues? But of course, the problem with that argument is if they did have a normal one, that could be their only ever chance of a normal one. So not investigating them is bad. So I'm trying to explain to you these questions on who we should investigate actually aren't all that clear. If we go back to the traditional thing, which has driven me mad for years and drives me even more mad, the way we decide who to investigate around the world is to count how many miscarriages people had. This is 2026. We have sequenced the human genome. Some trains actually go, but no, with miscarriage we count. And that is crazy because if you look at this graph, there's a stepwise increase in miscarriage. So every time you miscarry, you're more likely to miscarry in a future pregnancy. So if you're going to be logical, you should investigate after one miscarriage. So we have tried to put those two facts together by given some data from people who attended the miscarriage clinics across the Tommy's Miscarriage Centre to mathematicians. And they came up with a formula and then drew me these graphs. So you can see with each miscarriage, if you've got a normal body mass index, your chance of miscarrying increases and your age increases. So can anybody say, oh, at a certain risk of miscarrying or a certain probability of having a live baby, then we need to investigate them or not. So, and again, there's two sides of the argument, isn't it? So if you're a young woman and you've only had one miscarriage before, you've got 80% chance of having a baby, so you don't need investigating. But we don't know that those 20% that don't have a baby are not having a baby because they're losing normal pregnancies. Do you see what I mean? So I think we've got to fight against this number thing. And then if you then do all those graphs, plot all those graphs again with someone who's got a high BMI, you can see the whole thing moves down. So clearly, lifestyle advice is really important. But I'm just trying to say that we should fight back against simply counting numbers. We could have probability of a live birth. There's all sorts of other ways we could decide who to investigate. But I really want us to move away from counting, if it's at all possible, whatever healthcare system you're in. So when I write papers, and I do, this is why I'm passionate. The other thing, this is how annoying it is to be an academic. I've done several large-scale randomized controlled trials, so I clearly enter people who've had 2 miscarriages in my trials, because clearly they're a high-risk group. But is there any referee in Europe who understands that? Oh, no, you've only got miscarriage if you've had 3. That is what you get from the referees when you put a paper in. But not look at you. I'm sure you don't say that. It is bonkers. Do you see? So that is old-fashioned idea. That is not acceptable to women today. We've got to stop it. However, the problem is having decided which group of people you're going to investigate in your healthcare system, you then got to say what tests are worth it. And when we did the systematic review for this Lancet series, sadly, we didn't come up with all that many tests. We came up with thyroid tests because there's a strong association with subclinical hypothyroidism and even one miscarriage. So subclinical hypothyroidism I'm talking about is a TSH just above the normal range with or without TPO antibodies. There is lots of literature on antiphospholipid syndrome, which is detected by anticardiolipin antibodies and lupus anticoagulant. There's lots of literature on uterine anomalies and miscarriage, and there's lots of literature on karyotyping. So that's all we came up with. So when we built our model that I just showed you, we put into that these covariates. So this model is based on very detailed, so very granular information of everyone who attended my miscarriage clinic. And we looked to see what would alter the model in terms of predicting your future live birth. And some of the things we've just said, so age, number of previous miscarriages, whether you've had a live birth or not, or whether you've had a high body mass index or what your body mass index are, all important. But the other thing that came out important was polycystic ovaries. Now that didn't come out in our systematic review for our Lancet series, but it does come out very clearly in mathematical modelling. But there was lots of things we couldn't put in the model, not because they're not important, but because they didn't occur frequently enough in our data set for us to be able to put in the model. So one of the big issues in the UK at the moment is inequalities in healthcare. So the problem is if you're black and you enter the UK NHS and you're pregnant, you're 3 times more likely to die in childbirth than if you're white. And this is a big scandal that we're desperately trying to address. So that's why ethnicity is such a big issue. And when I did my model, I realised to my horror that very few black women attended my miscarriage clinic. So in my hospital, 40% of patients who deliver are white, but 85% of people attending the miscarriage clinic were white. And so clearly the more of the white population managed to get to my miscarriage clinic than the black population. So clearly there's inequalities in access to our NHS healthcare. And in fact, this model has sorted the problem, which I'll explain to you later. So basically, when we say who we can investigate, and I'm trying to say to you, 1 miscarriage is enough. But obviously, we haven't got unlimited healthcare budget to do unlimited expensive tests. There's lots of things you can do for people with 1 miscarriage. You can talk about their body mass index. You can talk about not smoking. That was associated with miscarriage. You can talk about not drinking. That was associated with miscarriage. You can dare to talk about shift work, as Tom mentioned. That was associated with miscarriage. And you can live in a lovely countryside away from pollution. I'm being sarcastic. but basically, the point is environmental features have been associated with miscarriage. So when we did the Lancet series, that my aim was to try and revolutionise the way we think about miscarriage. So we came up with this concept of the graded model of care, so that after 1 miscarriage, everyone should have some care. Now, I know we haven't got enough resources in any healthcare system for them to see a consultant, but by care, I mean online care. So that would be some sort of online things, opportunity to at least get some sort of online counselling. And then after 2 miscarriages, we would recommend full blood count and a thyroid function test. So the full blood count is, there's another sort of scandal that's going on in our NHS at the moment. So our gynecology services are so poor at the moment that we actually have people coming in with a hemoglobin of 4 to our emergency services from their heavy periods. So, so we've got a massive problem in the UK with anemia. Anemia has been strongly associated with all poor pregnancy outcomes. Whether I'm hoping that Scandinavia, that's sitting next to this lovely woman from Norway, isn't quite so bad, but maybe, I don't know. And then after 3 miscarriages, then we would say, well, now your chance of miscarrying is now high, and therefore it is warranted to do a large number of tests. So because we don't have huge amounts of resources in the NHS, with Tommy's, I developed this thing called a miscarriage support tool. So it's an online tool, and embedded in the tool is the formula that I was showing you earlier that looked at the number of gives you a chance of a live birth based on your history. It also gives you lifestyle advice. And then they've also got other things on their website that, for example, tell you about exercise. They point you to exercise regimes, stop smoking regimes, keep making sure your vitamin D is adequate. There's a very big shortage of vitamin D in the UK, and so that's been associated with recurrent miscarriage in meta-analysis. And so the aim of my miscarriage support tool was to get everyone in the UK who has had one miscarriage some sort of information and care. And the second aim was to make sure that the number of black women attending my clinic mirrored the local population. And because it tells you, the idea is the tool can't tell you, it asks you what ethnicity it is, but it doesn't give you a differing advice. And it tells you that you have a right to be seen at a consultant miscarriage clinic. And it actually works really well. So now the proportion of black women attending my miscarriage clinic, it mirrors my local population. So I'm delighted. So I've achieved my little goal. But the other thing we did with the tool is that we asked them if anyone would allow us to use their data for future research. So these are the results of, this tool was used far more than I thought. So in the first 2 years, over 100,000 people used it, but of those, 73,000 allowed us to use their data for research. So this data I'm going to present to you now is very different from the data I showed you before. So this is patient-reported data. So everything I have to say needs to be qualified by, so if I say ethnicity, the patient wrote, I haven't seen these patients at all. The patients have put that ethnicity in. They've put in their postcode, and there's a software program that automatically turns a UK postcode into index of social deprivation. So that's how we did deprivation. And the rest of the history, like the body mass index, patients put it in. So how accurate that is could be debatable. And then we ask the patients simple questions like, do you have diabetes? Do you have fibroids? No information about the fibroids. Do you have polycystic ovaries? Yes or no? So this isn't like a doctor taking a history or any doctor verifying it. It's patient-reported data. But I think it's fascinating, but I'll see what you think. So first of all, we looked at, and then our outcome measure was comparing people with high number, does anything predict those who've said they've had a high number of miscarriages? It's just all the data when they first put it in. For this lot, we don't have outcomes. So we found that those who reported higher numbers of miscarriage were more likely to be black, exactly what we expected from the, or more likely to be self-reported as black ethnicity, exactly what we expected from the Lancet series. So now a big question, well, why? So why is it that in the UK, black women are more likely to miscarry, and is there anything in this data that's going to give me a clue? So we looked at the age distribution and the index of social deprivation in people self-reported black, self-reported Asians, and self-reported white. So all spotted. These are very crude ethnicities, but this was for analysis to see if I could see any potential reasons. And there's a little bit of difference in the spread in the BMI and the age and the index of social deprivation in those 3 groups. Nothing, which is basically what we expected. And of course, the other thing, which of course you're all going to have expected, is the incidence of comorbidities is very different in these 3 groups. So particularly, as we'd expect, black women reported more fibroids, Asian women reported more PCOS and more diabetes. So now we're thinking about, actually, whilst we have a big problem in the UK is the outcomes of black women, Asian women, and white women are different. Lots of things are different. They've got different BMIs, different age, different index of social deprivation, and different comorbidities. So of all those factors, which ones are important? Which ones tell me why black women have more miscarriages than white women? So Warwick's got some fantastic mathematicians, and to be totally honest, I can't really explain the details of this because I might get it wrong. But anyway, in a nutshell, I asked them to look at all this data and say, is there anything in there that tells you why the black women have more miscarriages than the white women, or the Asian women have more miscarriages than the white women? And this is the diagram they came up with, which I'm absolutely fascinated with. So actually, there's some things in here that I would expect. So one of the things that explains the variance was index of social deprivation and BMI. We are expecting it, but look what else was really important, fibroids. We have forgotten all about fibroids in the miscarriage world. So one of the reasons, so the narrative in the UK is the reason that black women have more miscarriages and worse obstetric care is because the NHS is institutionally racist, which may or may not be true. But this data comes out, it's much more subtle than that. Of course, the difference between why black women have more miscarriages than white women is to do with fibroids. And if you do a literature search on fibroids and miscarriage, the quality of the research is very limited. No one even looks at cofactors. So maybe it's not the NHS that's racist, maybe it's the research community who haven't investigated the thing that affects. I'm just throwing out challenges to you. So it's not just me. Although, anyway, so this is, I think, a new thing we've got to focus on. You know, that different ethnicities have different comorbidities, and those are the things that we need to focus on if that's your population of people you look into. So I think that's going to apply to all populations. So the other big thing in miscarriages, as Tom so eloquently told us already, is genetics. So this is the latest paper on genetics. There's this fantastic group in Denmark who are doing a huge amount of research. And they got this paper published in Nature where they've done whole genome sequences of mother, father, and miscarried tissue, and found out, to look at genetic abnormalities. But still, after throwing all that detailed genetic analysis at it, look what it is. I actually copied out their conclusions. 45% of miscarriages are normal, and we haven't got a cause. There is something out there that we really, really need to look into. So the reality is, unfortunately, there's still some miscarriages we don't know about, but of course there's also 55% of miscarriages are because of chromosome abnormalities, nothing to do with the mother. Surely we need to do better at working these two groups out. And it really is important, to the women to know whether you've lost a normal or abnormal pregnancy. And I'm sure that knowing this will be part of the answer to reducing the severe post-traumatic stress disorder and the guilt that Tom told you about earlier. This is the sort of thing that patients said when we did a qualitative study on what patients felt about being given their karyotype. Yes, because the first instinct you have, like, did I do something wrong, or was it me who caused it? That's a classic expression of guilt. And if you know what it was out of your hands, and if you know what it was genetically, and the baby there was no chance to live, like a normal life, probably it'd be easier to let go. So basically, a lot of people find understanding that they lost a trisomy 17 or 18, which are the most common causes of miscarriage, actually helps them deal with the guilt, and perhaps helps and also will help the doctor work out what's the future treatment plan. So because of this, I have been obsessive in our hospital in trying to get all the people who miscarry, having attended my miscarriage clinic, have their tissue karyotyped. And despite my obsessiveness, this is our results. So this is 227 people who had attended my miscarriage clinic and then miscarried again. And we found that, in fact, in 28% of them, we didn't get a result. So this is, we went to a lot of effort. So we asked the people who are doing the surgical management miscarriage to make sure they sent it to the genetics. We collected miscarriage tissue if they had medical management of miscarriage in the hospital, if they had medical management of miscarriage at home, or they miscarried at home, we gave them POTS. And then we took it to we sent it to the genetics analysis. So this is within the context of the NHS. This includes all the people who put it in formalin, it gets lost in the transport, and all these things go wrong. So you can see that, whilst you get a higher yield from surgical management of miscarriage, it's important to realise that not everyone who has a surgical management miscarriage gets a genetic result. So sometimes the genetic tissue was too big a gap between them miscarrying and going to the surgery for the tissue to be anything analysable. Sometimes it got lost. Sometimes people put formalin on it, and all the other things that go wrong in real life. And it's really, really important that we get genetic analysis, because if you use your intuition, you get it wrong. So if you're scanning someone at 10 weeks gestation and you see a fetus, like I think we saw in the cases in the last session, and there's no fetal heart, you think, oh, well, it looks like it was a normal pregnancy and there's no heartbeat. But actually, this massive study from Hawaii of 30,000 pregnancies shows that actually the miscarriages diagnosed at 10, 11 and 12 weeks gestation actually far more likely to be abnormal than normal. So actually looking on an ultrasound scan is not really going to give you an idea. So this was my solution. But I'm not going to receive any money for this. So I designed this special collection device, which is obviously very simple, but we did lots of 3D printing and made the size of the holes such that the blood will go through the device and the miscarriage tissue will sit on the top to help people capture their tissue. These are people having medical and surgical management miscarriage at home for two reasons. One is so that we can get genetics results, but the other one is a lot of people tell me in my clinic that the reason they're traumatized is because their miscarried tissue went down the toilet and they can't live with that. And they tell me all sorts of weird stuff that can't be true. Like I had an 8-week miscarriage and I saw it looking out of me from the bottom of the toilet. Well, you can't, because you can't see any eyes at 8 weeks. But that's what's happened in the head. And so I've just got this on the market. It's very cheap, and this company called Kimball make it. I'm not trying to sell it, but I'm just trying to tell you. Well, I am trying to sell it. And the reason it's embarrassing, the reason it's called the Quemby Cradle is we got a group of patients together to get a name, you see, and we gave them some names. One of which was Coventry Cradle. And they were my patients. Stupid me asking my patients what to call it. And so they all insisted on this. This is not my idea, so I'm a bit embarrassed. I'm a raging narcissist. No, I promise you it was my patient. I should have asked other people's patients, but because it's easy to recruit my own patients. Yeah, if we'd asked Bourne's patients, it would have been the Bourne Cradle. But Quemby Cradle slips off the tongue better. Anyway. But that's not really the answer. I mean, hopefully the answer, as Tom's already said, there's been this paper and Tom's done some excellent work that shows the same thing, that if you take a blood test at the time of the miscarriage, it's even a better way of getting the genetics. At the moment, the problem with that in the NHS is cost, like everything else. So what can we do about miscarriages? Well, I'm going to start with first do no harm, because we've just had this paper published in Fertility and Sterility. And again, this is from the very accurately collected data from people attending my miscarriage clinic. And actually having a cesarean then miscarrying puts you at increased risk of miscarriage. The reason this is important, in the UK, our cesarean section rate is between 50 and 60%. It's an embarrassment. So lots of people have cesareans because it's maternal choice. But when they make these choices, we need to, it's really hard to tell them the harms, because at the time, most of my patients, they only care about that baby, and trying to talk to them about the future is impossible. But if they've had miscarriages, I do think this should be in their equation, because after years and years of miscarriage, I have to be honest, a lot of even though they're first trimester miscarriages, they're still terrified right up to the moment they're holding a baby. And so that bit just before delivery, all this fear comes back. And so my miscarriage patients frequently choose cesarean, but I just think this is important in counselling. So because this is from the Tommies, we looked at the subgroup of people who've had more miscarriages, and then we also found that if you've had 3 surgical managements of miscarriage, you're more likely to miscarry again than someone who've had 3 medical or 3 conservative miscarriages. And if you've had 3 miscarriages before and a cesarean, then you're statistically increased risk of miscarry. So yeah, in a way, it's probably obvious, isn't it? Increasing surgery is not good for your uterus, but this is data to show what you probably suspect. So, having done all that, first of all, we're going to do no harm, and then we're going to do lifestyle advice. So what therapeutics have we got? Not many, everything else. So we've got progesterone, thyroxine, and aspirin and heparin. So we've had a long history of data for aspirin and heparin for antiphospholipid syndrome. So I did a trial, and we wanted to say, well, what about people with inherited thrombophilias? So inherited thrombophilias are Leiden factor 5 mutation, prothrombin gene mutation, protein C, protein S, and antithrombin 3 deficiency. And so we worked with the Amsterdam group to randomize people to low molecular weight heparin injections every day or nothing. So this was the opposite of double blind. It was a very open label trial. And our inclusion criteria was inherited thrombophilia and 2 miscarriages. And then our outcome measures was primary outcome measure was live birth, secondary outcome measures obstetric complications. And we found absolutely no difference. So sadly, in order to recruit to this trial, which was really difficult, we did meet our power calculation, which was 326 people. We managed to use 5 countries, about 30 miscarriage centres from the UK and about 30 all over the place. And huge, huge work, absolutely no difference in the live birth rate. So that loads of people all over the world have had Leiden factor 5, no treatment at all except a nice doctor smiling at them, and they're just as likely to have a baby as if you stab yourself with heparin every day. This is devastating, but this is the truth. And then again, I got this one had managed to get accepted in the Lancet, but I got really interesting hate mail in the letters section because nobody wants to know this because they were very critical of the trial, and I would like to point out that we all think that heterozygous for Leiden factor 5 is a massive blood clotting risk factor, but we had lots of people. We had only 1 thrombosis in the whole study, and that was to someone who was already on heparin. We had no difference in the bleeding. Of course, the people on heparin were more likely to get bruising. And then we did a subgroup sensitivity analysis. So basically, even if we just look at the young people, or even if we just look at the people who are older than, who have more than 3 miscarriages, or if we look at different types of thrombophilia, indeed, there's no signal at all that heparin prevents miscarriage. My positive spin on my trial is I've saved lots of money if people believe me. So I'm now going to go on to the data about progesterone. This is another area of massive controversy in the UK. And there's been 2 massive progesterone trials led by my colleague Ari Kumasamri in the UK to look at whether progesterone prevents miscarriage. So one was the PROMISE trial, and the PROMISE trial, recruited people who had recurrent miscarriage, and the second was the PRISM trial, who recruited people who had bleeding in early pregnancy. And both the controversy is over the primary outcome measure results show no difference. However, if you then subcategorize this into people who've had 2, 3, or 4 miscarriages, there's a trend towards a difference in the PROMISE trial and in the PRISM trial. In fact, if you've just had 1 miscarriage before and you have bleeding in early pregnancy, progesterone seems to work. And so this is the area of controversy, how to interpret these results. And that's where there's lots of versions of this. So my version of this is so obvious, isn't it? If you've got a normal pregnancy, progesterone works, and if you've got an abnormal pregnancy, it doesn't. I can't see why anyone has any trouble understanding my point of view, but I'm a standalone person.
But Siobhan,
Yeah.
but you prescribe it because you don't know until the lady is pregnant. So
Yeah, exactly.
you do prescribe
Yes.
it.
So at the moment, I give. So if you've got recurrent miscarriage, you say, if you tell the patient, if it's a normal pregnancy, you can have progesterone. If you've got a normal pregnancy, it will work. If you've got an abnormal pregnancy, it won't. But I think it's really easy. But my strategy means I give progesterone to people with abnormal pregnancies. I might prolong pregnancy another week. I'm afraid when you've miscarried, it's awful. You're going to grieve over the baby. What's 1 week? But anyway, I've prolonged abnormal pregnancy a week. The other argument is, what if they have ectopic pregnancy? Well, it's not going to kill you having progesterone if you've got an ectopic pregnancy. I don't see that as an argument. Lots of people say there's an argument. The other argument is some of my colleagues in the UK think that there's an association between progesterone and autism, but actually if you look at the data, it's threatened miscarriage and autism, not the progesterone part. So I don't agree with that argument. But that I can assure you, I'm on a team of 1 with this. But and obviously, if you think about this meeting, I think Tom gave us the answer this morning. Clearly, the answer would be, Yes, of course it is. That is, you have a threat of miscarriage, blood test, normal karyotype, progesterone, threat of miscarriage, blood test, abnormal miscarriage, none. That's what we need to move to. We need to move to the future. Stop having arguments about, oh, well, you can only have progesterone if you've had one miscarriage before. That's what we do in the UK. Please, in other countries, can you have some sense? But, oh, no, in the UK, oh, well, one miscarriage, oh, you haven't had a miscarriage before, so you could just lose this one. That's how we carry on. That's my academic colleagues for you. I'm so popular. Right, look.
You do know this has been being
That's right, they all know. So the other thing that's very controversial is resecting septums. There's a strong association between uterine septums and miscarriage, but this randomized controlled trial done by my colleagues sadly showed no difference in those who had septum resections and those who didn't. They got the same amount of hate mail as I did, so I'm on their side. There's one trial that's interesting that suggests a benefit, which is using IVIG. And what they did, this is a Japanese trial, and what they did very cleverly in this trial is they only used people with 5 miscarriages, so only using a really terrible phenotype who've got a high chance of losing normal pregnancies. So maybe that's why they showed a benefit. But IVIG isn't available on the NHS. It's a single-centre trial and probably would need repeating before we put it in all our guidelines. And lastly, I'd like to finish up by, I published this data some while ago. This is people who attended my recurrent miscarriage clinic, and I followed them up for 2 years to find out how many had a baby. And my shock is, whilst 40% hadn't had a baby, of those, 20% never got pregnant again. We then interviewed them and found out the reason they didn't get pregnant again was fear. So I think we go right back to the full circle to Tom's excellent work. You know, remember this is a psychological thing. Remember a lot of your patients are too scared to get pregnant again. We really need to work on the psychology, or rather as well as the small number of people for whom we yet haven't got a solution. So in conclusion, I'm trying to tell you, one miscarriage matters. Do not count them. We've really got to concentrate on the mental health effects. We can give everyone lifestyle events and try and personalise their care. Thank you for listening.
Siobhan, thank you very much. Is there anyone else you'd like to insult, or have we finished? Are you sure? I mean, there must be a few members of the obs and gynae fraternity you've not touched on so far. Any questions from the floor? There's a question at the back. If you could just give the microphone.
My question is about NIPT. So I'll give you context. I had a couple a week or two ago who have had their 3rd miscarriage. They're going through their 3rd miscarriage, not consecutive, but they're desperate for cytogenetics, and they're due to be seen in the recurrent miscarriage clinic. And they've been, by the time I saw them, I've scanned them and it looks like RPOC, but they've been traumatised by trying to catch tissue at home over Christmas. And the husband turned around and said, why can't we just do a blood test? I'm hearing about this blood test. Why can't we just do a blood test? And I had nothing. I didn't, when I looked back through their scans, the scan that diagnosed miscarriage, the MSD was like 13 millimetres and they thought they saw a CRL. You really have to convince yourself when you go through the images to say you can see that CRL. So they had very little potential tissue anyway. And when I scanned them, endometrial thickness is about 9 millimetres, but there is vascularity, so I've called it RPOC at this point. And they're still just saying, well, what can we do? We want this information.
So we don't, yeah, exactly, but we shouldn't accept this happening. So first of all, on the NHS, on the 3rd miscarriage, you can get it karyotyped.
So we did offer 2,
Yeah,
so that's why she's trying to collect it.
Yeah, and so you need to buy my Quemby cradle. And then remember, and also remember, it's not the fetus that they karyotype, it's the trophoblasts, it's all that masses of villi. So the reason it fails is because it's a horrible job, and I don't really expect us to do it. But if you really want to do it, what we would have to do is personally get the miscarried tissue and pick out the villi, because it's actually currently done in the NHS by technicians. And so if you only send decidua to the lab, then they don't get a result. And we all know what villi look like, but it's not a very nice job, is it? So even in your retained products of conception, you know, presumably you're saying it's not just decidua, you've still got blood flow, there will be some villi, and then they don't have to grow it because they can use qPCR and CGH ratio. My frustration, it is possible to get a result. So if, for example, you're one of these clever people who can do hysteroscopic removal of retained products, you can then get that tiny bit, if it's villi, then, and send it to the lab and they can get you a result. Do you see what I mean? But this is what I was saying to Tom over lunch. I think we should campaign for NIPT. It would be so much easier if we could do a blood test. But maybe the private sector will start offering it. Who makes money in the private sector? We need some.
Apart from Osama.
Osama. Is it, do you see what I mean?
But
Because I think people.
Option for them,
Yeah,
if they wanted to go
but
private,
for £200,
could I-
you isn't it? If you do NIPT for how much do they pay for NIPT for Downs? Is it 200? Is it about 200, 300? 300. But £300 to save your mental health, it's a bargain.
Yeah.
That's what I think.
So
So
in
maybe
the
we should
future,
campaign for that.
If I am asked, or I might just write to them anyway, because I feel like I left them without an answer. In that they couldn't they? That could potentially.
Well, the
give them
trouble
a
is Harmony just 1321 X and Y?
Comes with a package with an ultrasound scan as well, but it's not only a blood test.
Yeah. So the problem is most miscarriages are trisomy 16, 17, or 18, whereas Harmony just does
Right.
21, 22, 18 X and Y, isn't it? Is that right? So do you see what I mean? So we need. So it's not available even in the private sector.
Illumina platform.
But maybe we're not demanding it enough.
It depends on the platform you're using. I mean,
that right?
Illumina does more.
But can you get Illumina in the private sector?
You can.
Oh, there.
I mean, clearly we're not quite at the point of having an IPT adopted at the moment. But I mean, in answering your question theoretically, number one, it was interesting that having retained pregnancy tissue only still gave us results, which is surprising. Obviously, we haven't worked out how long, but I mean, that gives some hope that some people who come in, even in your situation, which I accept is difficult, might still give some information. Second thing is obviously we know that if someone comes in with an empty sac or whatever, actually the risk of miscarriage is very high. I mean, you can work it out pretty much from our data, 16 millimetre empty sac. So it may be that a strategy would be to take blood from those patients, knowing that the risk of miscarriage is about 90%, because you will almost certainly get a result at that point, which you could then use if necessary, should unfortunately things end up. So you can even keep the sample or waiting events. I think that might be a strategy as well. I'm not quite sure which will be the best one, but I think there will be a solution for the situation you find yourself in.
And just from because they did have a live birth a few months earlier.
Yeah.
So fetal DNA wise, I don't
That's
actually
gone.
know.
No, that's not
Could
an issue.
that impact their result?
No.
That would have gone.
No, yeah.
Thank you.
That's a fantastic question.
Okay, I think we have one more question or comment.
One online question, whether the miscarriage support tool is available also outside UK.
Yeah, yes, I'm afraid it's only in English, and obviously the postcode isn't irrelevant. So when we first launched it, I'm so embarrassingly English. It was all set up for people in the UK, and to my great shock, people used it all over the world, and even in Australia. So we have had good feedback from there. But the problem is I'm not allowed, because of confidentiality, I'm not allowed to see it, but it is possible to know their IP address. So we had some people who actually were in Spain but gave a UK postcode. And so the thing that really shocked me is I've realised that the other fantastic thing about online is you can do it on holiday. So if you've had miscarriages, maybe you can't even face about thinking about it. But the great thing about online is you can do it anytime or on holiday or in another country. But yes, they can use it
You
anywhere.
could use a VPN.
Yeah.
It's possible.
Oh, sorry.
Okay.
I mean, the burning
but
question
any
I'm
country,
getting.
but it's only English.
I've got
Thank you.
thousands of questions saying, is the Quenby Cradle available internationally on Amazon?
Yes, Kim. Not Amazon. Not Amazon. Kim.
You need to sort your marketing out, Amazon.
Okay.
I'm not.
One quick question, very quickly. Lady there.
I just wanted your opinion in terms of, you've told us about some of the tests that we do and some of the tests that we do that actually don't make a difference. Do you think we over-investigate these women?
Yeah. So the reason we over-investigate is because we haven't got the karyotype. So we all know that there's thousands and thousands of people who have medicine, and that they lost a trisomy, they've lost several pregnancies with aneuploidy, so trisomy 15, trisomy 17, and then they get all sorts of treatments, and it's terrible. And it would all get solved if we have the NIPT when they wanted it. So we're going to fight for it.
Okay, Siobhan, I think we're going to have to close here. Thank you so much. Obviously, very thought-provoking. And